All right. Chat here. All right. Okay. So let me know if you can't see that screen. I'll kind of assume that people are seeing what I'm seeing. This is a pretty straightforward group of medications. They cause both sedation and hypnosis. Surprise, surprise. These are the groups that were specifically mentioned in uh, the C-SPI manual. So this is the ones I'm going to go through. Um, barbs, benzos, Z-drugs, buspirone, and chloral hydrate. So the barbs come in many varieties. We don't see a lot of them anymore. It used to be, at least we had phenobarb sticking around for pediatric seizures, but that's been, usurped with all of the newer anti-convulsants, which is a good thing because, frankly, they're kind of dangerous drugs. So, but they get broken down into long, intermediate, short, and ultra short acting. The ultra short acting are mostly used for or historically were used for things like induction for intubation. Um, and then the longer acting ones, particularly phenobarb, for things like seizure prophylaxis and things like that, and sedation and anxiety and things like that. So the trouble with them is the trouble with the barbs in general is that they have a relatively small, narrow therapeutic index. So the distance between therapeutic and dead is not very wide, and so it's good to see that they're not being used as much. Like all of the sedative hypnotics, they cause CNS sedation. They do cause respiratory depression. There's little debate about that. You can take an oral overdose of barbs and stop breathing. They also may lead to hypotension and hypothermia. And then barbs are one of the drugs that I would say causes a lot of hypotonia. And what I mean by that is if you lots of sedatives like benzos, you will be unconscious but still have some muscle tone. Barbs tend to have very little muscle tone at all. The other drug I would throw into that group would be GHB, where they really truly just don't have any tone. Like clinically, they're lying on the gurney and their arm will just flop off to the side. Whereas with benzos and other sedatives, they tend to have at least a little bit of tone. There's a couple of unusual things to recognize about barbs. There's this thing called barb blisters, and I think this has a lot to do with that hypotonicity. They tend to develop everyone develops pressure ulcers in areas that they're laying on, right? If you're sedated, you can't roll over. And so, your scapula are pressing to a very thin skin into concrete. And so you're going to get pressure ulcers there. You're going to get them on your gluteal area. You're going to get them on your ankles and shoulders. So these are common, these are common with all sedatives. There does seem to be something about barbs that cause these big fluid-filled blisters. Whether it's something specific about the drug, I think it's probably because they're much more concentrated, because at least with a benzo or with alcohol, you shift a little bit and you take a little bit of pressure off that. And I think these areas are essentially necrotic. So, but you should know that there's a thing called barb blisters and that there are pressure areas of the where the person was found. Barbs also are sort of a classic brain death mimic. And what I mean by that is that the sedation can be so profound that they lose all of their brainstem reflexes. So phenobarb overdose, day 2, the hypotension is gone. And they are just unconscious on a ventilator with no respiratory effort. no corneal reflex. You do all of those reflexes and they're all normal. And so this has been one of those mimics where people have started trying to determine whether they're brain dead. Remember, you can't be brain dead if you are under the influence of a sedative. And I think even more importantly is you can't be brain dead with a normal brain, right? So all of these patients with brain death mimics have a normal CAT scan or MRI. That's not possible to have a dead brain and to have a normal MRI, right? So it has to have an oxic injury, it has to have cerebral edema, it has to have something that killed the brain. If the MRI is normal, then that's much more likely to be a drug effect, and barbs are a classic. All right, most of the diagnosis of overdose is clinical. We do have access to phenobarb concentrations, and they do correlate fairly well to what you see with coma over 60 milligrams per liter, and more severe effects like hypotension, refractory hypotension at much higher concentration. And of course, for some reason, we still have barbs on our urine drug screen, even though nobody uses them. So you can always use that. So for most of the sedative hypnotics, I will say activated charcoal, but nobody ever shows up in the ED with wide awake after a sedative hypnotic overdose. So we're probably not going to use them because they're probably already obtended. But if we had some magic case where like they accidentally just took their entire bottle of phenobarb, I guess I would give it. Of all the barbs, the only real exception is phenobarb, and for phenobarb, you can do everything, which is great. You can alkalize the urine to increase excretion. You can give multi-dose activated charcoal. That is based on, I think I talked about it yesterday, a study where they gave IV phenobarb. Half the patients got multi-dose charcoal, half didn't, and the half-life of phenobarb is decreased by oral charcoal, even though the phenobarb was given IV. So that's that gut dialysis. And then hemodialysis for severe symptoms or a phenobarb over 150. Phenobarb over 150 is just a marker for severe symptoms. So it's kind of the same thing. X-Trip actually mentions for prolonged coma, which I thought was kind of interesting, doing hemodialysis. I suspect that would be, day 3 of a phenobarb overdose. They're still unconscious, non-emergent daytime hemodialysis, which seems not unreasonable to wake them up. And just a reminder that the X-Trip, if you just Google X-Trip and the and the substance, it'll come up, and they do have a whole thing on barbs. But I can let you know that it's just phenobarb. Okay, benzos come in all shapes and sizes. This is probably not even an entire list. And of course, there's a bunch of benzos that are coming up now, like atizolam, that aren't indicated in the United States, but our patients may be taking them because they ordered them online or because they came in their pressed Xanax tablet or something along those lines. Benzos, sedatives, they're GABA agonists just like the barbs. They cause sedation, not really very surprising. Pretty much a slightly milder version of the barbs. There is one thing that seems to come up a lot. I can't imagine a question on it, but I just want to say it out loud. There is a belief that you can't get respiratory depression from an oral benzo overdose. So I've said it out loud. Unfortunately, for people who say that, you can get upper airway obstruction. And so if you take enough benzos, you can have CNS sedation, and your head can be tilted off to the side. Your tongue can obstruct your upper airway, and you can die from that. So I don't know why people get excited about that concept that you can't get respiratory depression, but I think the point is an oral overdose of benzos, your brain does not get apneic. You still send signals to breathe, as opposed to like an opioid, where your brain just stops telling your diaphragm to move. So that's clinically not particularly important, but it's so ingrained in medicine, I feel like I needed to say it out loud. So again, probably too sedated. Flumazenil, if you truly have a benzo overdose, and what I would say is, um, you're going to intubate them, because if you're not going to intubate them, then there's probably no good reason that they need to wake up. They can just sleep. But if you're thinking, I might, intubate this person, and if they reverse the flumazenil, I won't. Then I like flumazenil for that specific scenario. In particular, because as we talked about before, of course, a million times, it's possible you could induce benzo withdrawal, although still trying to find a case where that actually happened. You can get seizures if if it's like a big someone took tricyclic or bupropion and lorazepam, you reverse their benzo. But I think this is a great case for, I'll tell you one case that I had once was a mom who took out her Valium, and I think it was 2 10 milligram tablets. She put them on the counter. How many times have you heard the story? Turned around to get the glass of water, right? And turned around, and there was her like 18-month-old chewing on the 20 milligrams of Valium. And that kid was really sleepy and really floppy. And I had to transfer the child across town to get to a peds hospital to observe him. And the paramedics were not comfortable taking a sleepy child like that. And so I gave flumazenil. The child woke up, hilariously walked to the ambulance for transfer, and sat on mom's lap for the transfer, and then got to the pediatric hospital, and then got sleepy again about an hour or so later. So there are scenarios where this is really, really helpful, but we have to recognize the contraindications and be careful. Phenobarb, I see your question. I don't think that phenobarb undergoes enterohepatic circulation. The reason we are giving multi-dose charcoal is because of the gut dialysis concept, that phenobarb is going to just move out of the blood into the GI tract and then get adsorbed to charcoal. And while that sounds super far-fetched, I agree. It does actually work. All right, the Z drugs. So these are hilariously marketed as non-benzodiazepine sleep aids, but they bind to the benzo receptor. And so the reason why they are non-benzodiazepines is because they have a slightly different structure. And benzodiazepine is a benzene with a cyclic structure with 2 nitrogens. That's why it's diazepine. And the Z drugs have a benzene with a 2 nitrogen, but it's not a 7-member group, it's 5. And so but it binds to the benzo receptor, so it acts exactly like a benzo. They tend to be very rapid in onset. If you've ever taken an Ambien or any of Lunesta or any of these things, their onset is very, very quick. And they have the exact same toxicity that benzos do. You get really sleepy. Can you stop breathing? Well, you probably can if you are sort of in a position that does not, where your airway is closed. You certainly can die, and there have been deaths that are associated with it, but generally they do pretty well. One note is, because they bind to benzo receptors, flumazenil is a perfectly reasonable reversal agent for all of the Z drugs. So I suppose that could be a question as well. We don't see this very often. We don't need to use flumazenil very often because most people who take these drugs do fine. Or it's a mess. It's like, they took Zolpidem, but they also took 7 other medications, and we're not going to be reversing them anytime soon. So, but if you got a kid again, same thing, some 2-year-old who takes, 5 of their parents' Ambien. This would be a very reasonable thing to do. All right, Boost Bar. There's not a lot that's exciting. I mean, most people do fine with buspirone ingestions. Um, you know, most of the people I have seen have been relatively asymptomatic, and I don't know why the manual specifically specified this one as a separate sedative hypnotic, but there's nothing really very exciting about it, honestly. So, but there's no reversal agent, it's just supportive care. And then chloral hydrate's a really interesting drug. Nobody uses it anymore. I suppose you could probably order it on the internet. It used to be really common for pediatric sedations, believe it or not, for like going for a CAT scan way back when CAT scans were just like this, like squint and it's like white dots and black dots. But they would sedate kids with chloral hydrate because it was an oral med, which was, the nice thing about that. So you didn't have to do an IV for children. Um, and it is metabolized to trichloroethanol, which is also a sedative hypnotic, so it has pretty long um, uh, activity. Unfortunately, it also sensitizes the myocardium to catecholamines, just like huffing does, right? So huffing is trichloroethanol is one of the things that people huff that causes sensitized myocardium and causes sudden sniffing death. In this case, you're giving a liquid chloral hydrate, gets converted to trichloroethanol, which can cause ventricular dysrhythmias. So it is not used very often anymore. I know that we did have someone buy it on the internet a couple of years ago, and was just like, sipping it at home. But I think that would be difficult to do. The tricky part about this, just like sudden sniffing death, because of the sensitized myocardium, you can try something like esmolol to slow to decrease their it's not sensitization, but decrease their catecholamine surge, which is what causes the ventricular dysrhythmia. So esmolol is really more of a prevention of VTAC than a treatment. So I would, if they were in a dysrhythmia, I would treat them for their dysrhythmia. But as soon as they get ROSC, I would probably start esmolol. The other fun thing about chloral hydrate is, at least theoretically, it was used as a quote unquote Mickey Finn, which is like you increase the sedative effects of ethanol or you prolong them. And the reason is because they both use alcohol dehydrogenase. And so taking chloral hydrate with ethanol, chloral hydrate inhibits ethanol metabolism, ethanol inhibits chloral hydrate metabolism. They both last much, much longer. So you have this sort of synergistic effect. And whether this actually has ever been used or not, it's a little bit debatable, but it does have some interesting history behind it for sure. So that is all I have for sedative hypnotics. See if there's any questions. I think they're pretty straightforward. They cause you to be sedated. I think I remember the flamazanil as a possibility for Z drugs and for benzos. All right, why don't we take we want a 5-minute break? Does that sound good? 5 minutes, we'll be back at 10:54, 10:55. Cool.